Dr. Jo Morrison has worked as a consultant gynecological oncologist at the Somerset Gynecological Cancer Centre in Taunton since 2010. She specialises in the surgical treatment of gynecological cancers, colposcopy and vulval disease. She's an honorary senior lecturer at the University of Exeter and holds an MRC-funded Clinical Academic Research Partnership Award. In addition to providing a comprehensive gynecological cancer service, she's also the coordinating editor for the Cochrane Gynae Cancer Group until it closed last year, and she's now the associate editor for gynecological cancer in the Cochrane Sexual and Reproductive Health Group. She's also editor-in-chief of the Obstetrician and Gynecologist and is co-chair of the BGCS guidelines subgroup. So it's an honour to have you speaking with us today.
Thank you ever so much for asking me to talk today. It's a really interesting programme and some great speakers. Hopefully you can see my slides, can you?
Yes.
Yes, excellent. So hopefully we'll move along now. First we should start with our conflicts of interest. So where I have no industry funding, we all come to a topic with our prejudices and conflicts of interest, be they commercial, intellectual or otherwise. As a newly qualified doctor, I had the privilege to work for this man, Professor David Sackett, who was a Canadian from McMaster University and one of the grandfathers of evidence-based medicine. He came to Oxford to set up the Centre for Evidence-Based Medicine. I worked for him as his house officer. So not only was Prof Sackett a great doctor and a very kind man, but he was also an inspirational teacher. And he taught us to question the evidence for all we do in medicine, giving everyone from the senior reg to the student an evidence prescription at the end of each teaching round. We'd look up the evidence for anything such as whether there was benefits of viewing fundi to diagnose papilledema or the number needed to treat with antihypertensives to prevent one stroke. He taught us to ask why for everything we do now. So this doesn't necessarily make for an easy life, especially as a trainee in a surgical specialty, as asking why is often misinterpreted as a challenge to authority, especially when the boss doesn't know the answer. But it is important to constantly challenge our own and others' assumptions. So I may be constantly offending you during this talk, for which I only slightly apologise. So what is the rationale for removing lymph nodes in endometrial cancer, and why do we do it? After all, in cervical cancer, we know that those with involved nodes benefit from chemoradiotherapy and that a combination of surgery and chemoradiotherapy adds harm without any additional benefit. Similarly, there's no advantage in doing so for non-bulky nodes in advanced ovarian cancer, which we know from the LINE study. So we have to ask ourselves some questions. The first are, does removing nodes improve survival? This may be for debulking large nodes, but what about nodes that are not obviously involved with tumour? Could this be directly beneficial if removing microscopic disease helps, or could it be indirectly helpful if nodal status changes adjuvant treatment, which then leads to better outcomes? And is this beneficial in an era of molecular characterisation in addition to conventional risk factors? So the second questions are, if lymph node removal doesn't improve outcomes, is it useful to provide prognostic information? And again, does this give any additional information compared to modern molecular characterisation? Because things have changed radically in the past 5 years. And third, and most often forgotten, what are the harms of removing or sampling lymph nodes? So what do we know about the therapeutic effect of lymphadenectomy? So the evidence for removal of bulky nodes is based on retrospective observational studies. So both macroscopic resection of bulky nodal disease was associated with longer disease-specific survival in patients with stage 3 disease compared to those left with gross residual disease. But as we know, these data are subject to very significant bias, as older and less fit patients with poorer prognosis are less likely to have the more extensive surgery in order to remove all nodal disease. So these studies are now quite old, predating the introduction of immunotherapy, and it would be interesting to see if the effect of MMR status on these data. A large retrospective analysis on the SEER database found that those with paraortic positive disease did poorly, regardless of treatment, especially if they had non-endometrioid histology. Paraortic node dissection on top of pelvic node dissection was associated with better outcomes, but again, these are non-randomized data with all of the usual caveats about association not equaling causation. But we do recommend removal of bulky nodes based on these data. So what about presumed early stage disease? Does routine lymphadenectomy versus no routine lymphadenectomy improve outcomes for presumed stage 1 endometrial cancer? And what are the harms? So 2 key studies involving nearly 2,000 women found no difference in overall survival with routine lymph node dissection compared with only removing bulky nodes. These studies also recruited grade 3 patients, and the findings were similar in those patients, but without adequate power to be statistically significant in this cohort. There was no benefit in progression-free survival either with lymph node dissection. In fact, both studies suggest that the opposite may actually be true if you look where the error bars are and where the point of effect is. What is clear is that lymph node dissection does cause an increase in surgical morbidity, which was increased fourfold in these studies, as well as an 8-fold increase in long-term morbidity for lymphedema and lymphocyst formation. As this is a cohort of patients who normally do well and survive for many years, this can cause significant and long-term morbidity, and we should be mindful of this. So it would appear that lymph node dissection for nodes not obviously involved doesn't help patients, but commonly leads to harm, and yet people still do this and have instead looked at ways to decrease the morbidity, forgetting that these studies didn't actually show any benefit. So could less equal more? Are we able to accurately predict lymph node status without removing all of the nodes? This is called sentinel node biopsy. When we consider the value of sentinel node biopsy, we need to consider what is the most accurate method for sampling nodes, and is it adequately able to predict node status? But also, we need to know whether this information is helpful to patient outcomes, or are we just doing less damage to patients by removing fewer nodes without actually helping? Sentinel lymph node biopsy technique has evolved over time with the introduction of new technologies. So originally it was quite similar to breast and plastics in that we used technetium-99 and blue dye, but now we have ICG technology and laparoscopic surgery, and they are now widely available. It can be a really lovely technique to do laparoscopically with pretty pictures, and is surgically very satisfying. The important point is to follow the lymphatic drainage to find the first draining nodes rather than go for green. Obviously, this patient is not necessarily your average endometrial cancer patient. You can actually see the lymphatics through the peritoneum on the picture on the left. Whereas the photos from my last patient with a BMI of 50 weren't as pretty, and we couldn't see anything until we opened up the spaces. The key is to carefully open the spaces without disrupting the lymphatics and trace the lymphatic drainage across from the parametria to the first draining node on each side. Studies have shown that cervical injections at 3 and 9 o'clock, both superficial and deep, work best, and you don't need to do hysteroscopic injection. It doesn't add to the technique. So the node removed is then sent for histology and undergoes what we call ultra staging, very finely slicing the node into multiple sections and using immunohistochemistry to detect even individual tumour cells. This technique therefore obviously picks up about double the number of positive nodes than you would with conventional lymph node dissection. So there's several questions that we need to ask about sentinel node biopsy. So first, what is the detection rate? Can you technically find the sentinel node? Second, how accurate is the test at looking at the sensitivity and ability to avoid missing a positive node? Interestingly, none of these studies blindly assessed the sentinel node with standard histology, so the specificity for the studies is by definition 100%. A Cochrane review sought to determine the diagnostic test accuracy of sentinel node biopsy in endometrial cancer. We found 73 studies that performed both sentinel node biopsy and then went on to perform full lymph node dissection in each patient at the same surgery. We were therefore able to extract 2x2 table data for these studies, which included just over 2,000 women. The mean detection rate was 86.9%, although 65.4% had bilateral lymph nodes detected. The pooled sensitivity was just over 90%. What matters most if you're going to reduce adjuvant treatment based on the node status is how many women will have positive nodes missed by the sentinel node biopsy. This varies depending on the underlying positive node rate. So in a high-risk population, about 1.4% will have positive node missed by sentinel node biopsy, whereas in a low-risk population, this risk is under 0.5% when a sentinel lymph node was detected by tracing. When comparing different tracers, ICG alone seemed to be as good as technetium 99 and blue dye together. And a very small study suggests that adding technetium 99 to ICG may be better, but the certainty of evidence is very low for this because this study was very small with only one positive node found in about 32 patients. So looking at the ICG studies only, there is a significant variation between the studies in terms of sensitivity, especially bearing in mind that these are only those patients in whom a sentinel node was actually detected. So what don't we know about sentinel node biopsies? The diagnostic test accuracy studies tell us that we can use sentinel node biopsy instead of lymphadenectomy to detect nodes, but as the previous studies that we've talked about already found that lymph node dissection doesn't benefit survival outcomes, should we? In an excellent review article, Obermeyer and Abu Rustam challenge our eagerness to adopt new techniques without an evidence base to support the intervention. This is especially pertinent with our growing knowledge about the prognostic implications of molecular characteristics of endometrial cancers. In a retrospective study, Hui et al. Found that molecular markers and presence of lymphovascular space invasion were better predictors of recurrence than those with LVSI but negative nodes. They concluded that, despite lymph node assessment in all patients, outcomes were significantly worse for tumours with LVSI and abnormal p53 expression. A negative lymph node may therefore be falsely reassuring, and these patients require adjuvant treatment. None of whom who did have adjuvant treatment did relapse within the radiotherapy field. A recent paper from the Mayo Clinic looked at the significance of individual tumour cells on sentinel node biopsy in low-risk patients. Note that a third of the cohort were excluded as they didn't have sentinel node biopsy performed or had higher risk. They combined with follow-up data from a study across 15 centres from across the US, and after exclusion included nearly 500 patients. 42 of those had individual tumour cells in the sentinel node, compared with 452 with negative sentinel nodes. They followed these patients up and reported progression-free and overall survival. Median follow-up along those without recurrence was 2.3 years, and the median time to recurrence was about a year. Those with individual tumour cells had a 4.5-fold increase in recurrence, whereas those with LVSI, regardless of node status, had a 14-fold increase. After adjusting for node status, LVSI increased the risk of recurrence 6-fold. If only those without LVSI were studied, presence of ITC made no difference on overall survival. It therefore raises the question, are uterine factors therefore better at predicting recurrence, and might node status be falsely reassuring? Obermeyer et al. Performed a systematic review of studies for sentinel nodes in endometrial cancer. Disappointingly, only 2 of the 21 studies reported any patient outcomes, and only 3 evaluated harms in terms of lymphedema rates. They found that sentinel node biopsy had no effect on adjuvant treatment rates, and the costs of sentinel lymph node biopsy and lymph node dissection were higher than not removing nodes. They concluded from this study that a study to assess no node dissection versus sentinel lymph node biopsy was required. Unfortunately, it would appear that asking people to wait for this evidence when they are keen to use a technique appears to be mission impossible. Even 5 years ago, the majority were performing sentinel node biopsy, and this is now likely to be much higher. So we still don't know how often sentinel node biopsy changes management in an era of molecular characterization, characterization, and more importantly, whether knowledge of sentinel node status improves outcomes. And this network map, showing all of the studies in this area, with those marked as with an asterisk as ongoing or halted or unreported. As you can see, all of the attention is on comparison of sentinel node biopsy to lymph node dissection. But as we already know, no lymph node dissection is probably better than lymph node dissection. So this is the most important question, which we hope Endo3 study, which is led by Andres Obermeyer, will answer in the future. In a national cancer database study of nearly 70,000 women, there was no difference in overall survival in patients with endometrial cancer who underwent sentinel node biopsy alone, sentinel node biopsy followed by lymphadenectomy, or lymphadenectomy alone. This observational study remained regardless of node status, histotype, and lymphadenectomy extent. Although this is not RCT level evidence, it does suggest that another arm of the triangle is likely to be equivalent. Medicine is littered with treatments that we assumed would make positive difference or would do no harm. Unfortunately, several examples come from gynae oncology, where enthusiasm to perform surgery or new surgical techniques may be unwarranted. Many questions remain with regard to sentinel node biopsy and endometrial cancer, and just because we can from the diagnostic test accuracy data doesn't necessarily mean we should. Molecular characterization and presence of lymphovascular space invasion may be better at guiding subsequent treatment options, and the number needed to benefit from sentinel node biopsy may be much higher than those harmed, either as a consequence of removing nodes or due to false reassurance of a negative node. We do not yet know how many patients need to have sentinel node biopsy to benefit one patient in terms of survival, not just to detect one more with involved nodes, and whether this is beneficial in terms of cost effectiveness, considered over the entire patient journey, including late effects of lymphedema and radiotherapy. Obermeyer and Adbu-Rostrom, in their excellent article, concluded that it is an urgent research priority, and we should remember that the value of sentinel node biopsy remains to be proven, especially in view of our increased understanding of endometrial cancer biology. Thank you very much for listening.
Thank you, Jo. That's fantastic talk.
Thank you.
Do we have any questions? Susie, Anna, any comments?
So I was just wondering, for low risk endometrial cancer, the ESCO guidelines say you can offer sentinel nodes. I wondered what's your personal take on that? Is it just, you know?
I mean, I think it's really interesting in terms of, you know, where it makes the difference. And I think that's just what we really need to know, isn't it? Personally, I don't, but we don't have a business case that supports us doing nodes in low risk patients. And it may be that that's actually the place we should be doing it, because the high risk ones, especially if they've got P53, probably just need more treatment anyway. And it would be really interesting to compare a group where we have data on sentinel nodes and lymph nodes and sort of blindly give the information to someone without knowing the node status, and then with knowing the node status, to see how often it actually changes your management. I suspect it's not actually that often, but I mean, these are all things that we need to answer, really.
And I think, you know, if we were to blanket introduce for low grades, we have to think about the implications that would take those cases potentially out of the units and into centres for sentinel node technology and techniques to be performed. So that would have, you know, big implications for the units and for capacity as well.
Very true.
Thank you,
Jo. Sorry, Susie, good.
Just checking any other questions, and I don't think there's anything in the chat. If there are any other questions, if you pop them in the chat, thank you very much. That was fantastic.
Thank you so much.
Move on to our last patient then before lunch. Anna, if you want to introduce.
Thank you, Jo.